I'm in a different room now. I'm actually still in the same room at home, but I'm on a different area of the timeline. So you heard the introduction there to our second panel discussion of the day. And my expert panel are Lisa Hollins, Director of Innovation Delivery, NHSX, Catherine Dale, Programme Director for Patient Safety and Experience, Health Innovation Network, and Alexia Pellowe, Clinical Lead, Remote Health Monitoring, NHS Ayrshire and Arran. And do remember, everyone, that you can put questions using the live Q&A button on the right-hand side of your screen. So good morning, ladies. It's nice to have a female only. Catherine, can you set the scene for us? First of all, if you would, what do we mean by remote patient care? I know that sounds a very basic question, but for somebody as a general journalist and for those in our audience who might not all be involved at the clinical end, let's just set our stall out. What do we mean by that?
Yeah, great opening question though, because it can be a bit of a jargon buzzword where people can be talking about a variety of different things. But I think this is all about healthcare that is not face-to-face. So it encompasses virtual consultations where you have an interaction with a clinician, either over the telephone or through video conferencing. And it also incorporates remote monitoring. So the kind of when either a gadget or some information that they're gathering in their own place where they're living, and that is being passed back to healthcare practitioners who then interact with people. So it does encompass quite a wide range of things, but it's about not being face-to-face in terms of that clinical contact.
Lisa, a good explanation there. Lisa, how has remote patient care changed over the last 3 years for you?
Well, we've seen a phenomenal rise over the last 3 years, as you could imagine. I think we're already starting 2 years when we saw some great examples of remote patient care. And it was mostly about giving patients the choice of whether they wanted to come into hospital, where they needed to do that, and whether they wanted to receive their care from home. And we have all the devices and technology that enables us to do that now. So it's much more around patient choice, but also many patients with long-term conditions. And I've got a long-term condition, and I've been desperate to not sit in an outpatient clinic for 2 hours if I didn't need to, because I know I'm perfectly well. So it's given people lots of choice, but it's also moved from people knowing their results every quarter when they visit their site. So having a very visit-based healthcare, if you want to know how well you're doing visiting a site, whether it's a GP practice or a hospital, to enabling people to be much more in control of their own care, their own results, and knowing what the parameters are, and knowing if they're deteriorating. So it has huge opportunities for clinical safety in terms of our patients knowing at a very early stage if they're deteriorating, and for some of our more severe conditions, that's really, really important for them to seek help as soon as possible. So we've seen examples for cardiovascular, respiratory, cancer care, and gastroenterology in a number of hospitals, and now we've seen that scale up substantially. One of the biggest changes was that we started, and it's part of the project I was involved in, started seeing remote monitoring for COVID patients, where the blood pressure, blood saturation was monitored at home through an oximeter, and those results were put onto an app and through to a dashboard that clinicians were monitoring, and that scaled really quickly across the country from 2 sites in the first wave of the pandemic to 120 sites, and we saw a real rise in people just knowing that they could monitor themselves at home, feel safe at home, and know there was a clinical team out there looking after them very discreetly, but contacting them straight away if there's any issues.
I didn't realise actually until I was researching today's event that so many COVID patients had been looked after remotely, and it seems to make so much sense on so many levels, I suppose. Alexia, welcome to the conversation. Last but certainly not least, tell us about the remote health pathways that you've introduced within Ayrshire and Arran Health Board, and some of the benefits that you've seen.
Thanks, Helen. Well, we were lucky, I suppose, in NHSX and Arran that we already had quite a few introductions that were done nationally first. So we had the BP scale up for blood pressure monitoring. We had Florence beating the blues for those suffering from low mood and anxiety. And we also had NHS Near Me, which was using Attend Anywhere software to be able to increase the video consultations. So we already had that going, and the opportunity was there to get sort of into the helicopter view and have a look and see what else we can support, as we were aware that the pandemic was going to be putting pressure on other parts of the system as well. We were really fortunate. In fact, we had our own local contract with a software company, and we were able to really have a look and see where else is the need. So we looked at primary care, and we saw that actually for primary care, those long-term condition annual reviews, as Lisa was mentioning there, were being paused, or that work then was being asked to be put on hold just while the main wave one was happening. And we thought, how else can we help these patients who are going to be sitting there and not avoid backlogs, and try to be able to keep the system turning and look to tech to be able to create some solutions to keep that cohort of people that are in need as well, keeping them safe and keeping them well monitored. So we have had quite a lot of input from all areas within the health board to be able to develop two streams of work. One is looking at the primary care annual reviews and looking at those that didn't require blood monitoring, because we knew our labs were busy already, and putting in some systems in there to be able to collect data from them in a time efficient way, remotely, using various solutions like text messaging, email, and also phone automated systems, get that information from patients if they were happy to do so. But then that was able to release some capacity we planned to be able to then have those conversations that are more important to patients, and it move away from a quality outcomes framework and data-based consultation, but actually looking for those in need and be able to triage those patients for who needs some input sooner and who doesn't. And the second stream of work we had going was then looking at those ones with conditions that needed blood monitoring, and to be able to devise a pathway that would help for those blood tests to be collected, but also for that support to be there for them as well. And the other thing that we actually did was, there's so much been going on over the past year.
It sounds amazing.
Yeah, we were looking at how to support patients to self-manage as well, and rather than go off into that ether that can be the internet, and there's so much information there. Is it safe? Is it relevant to me? Then we created a structured and supported self-management program for those newly diagnosed with COPD, and the feedback from the patients that we've put on those pathways has been really positive.
Gosh, I know you're a GP as well. I wish you were my GP, to be honest. It sounds like you've been doing some fantastic stuff. While we're just with you, Alexia, I just wondered, what kind of response you've got from patients, and whether most of them have embraced it, or whether some patients have found it difficult to adapt to remote care.
We did make sure, and we knew that some patients would be resistant to this. So I think I should make clear that these pathways are there to run alongside the current systems and not to replace them. So obviously patients have been asked first if they do want to go it. For the supported self-management for COPD, those patients at the end of the 2 weeks, the feedback was entirely positive, and they said they would recommend it to others. Those that used it had told their respiratory nurse afterwards that they'd learned more than they would have done otherwise, that they'd referred themselves into pulmonary rehab because they had that awareness of that and how important that was for their condition. And also simple things about how else they could self-manage. They said that was great, and they'd actually stored the information on their phone themselves so that they could refer back to it in a future point, which was brilliant. Feedback about the remote health pathway. There's one for asthma, so it's collecting that information for an annual review ahead of time. So that feedback was that they appreciated that they could do this in a remote way, and that they were relieved and glad that would still mean they were having their consultation as well. So it's quite interesting that there's an acceptance from patients that they realize this can free up time for them to be able to get what matters to you conversations going on within their appointment time. So yes, on the whole, it's been brilliant. And the BP scale up, that's been a national program Professor Brian McKinstry has been the pioneer and lead of. And the BP scale up, those monitoring protocols, there's 3 different protocols that allow patients to be able to either be monitored because there's been a change in their blood pressure, and that's quite close monitoring, or for them to be able to be monitored over a year's time, and so they can have sort of monthly feedback to the practices. And again, for BP scale up, there's been real passion and excitement from the patients to do it, to the point that we've actually been struggling to keep up with the supply of blood pressure monitors. So the scale and pace that has transformed all of the health boards that are using it has been brilliant.
Alexia, I'm glad you kept going there, because not only are you the clinical lead for TEC and a GP, you were actually the host briefly there when our virtual system threw me off. Catherine, I noticed you were nodding away, and I'm sure you've got things to add to what Alexia said. And also I was going to ask, we've heard a lot of the advantages of remote patient care, but are there any disadvantages as well?
Yeah, thanks so much. Yes, it's really great to hear about the work that's going on in Scotland, as somebody who's based in England, but who's really keen on, as part of the Academic Health Science Network, we are responsible for encouraging the spread of good innovation. And so I think there's real links between what the different countries are doing that we should learn from each other. And yes, so I think that, as we've all kind of touched on, there are some concerns about digital access particularly being something that can hinder people's access to healthcare. And I think it's particularly important at the moment where people are in the health system are even more acutely aware, because of some of the vivid pictures we've got from COVID about health inequalities. Health inequalities is such a key thing that we're talking about at the moment. And I personally believe that remote health is a real opportunity to tackle some of that, and to put our money where our mouth is when we're talking about being inclusive and enabling access, but to think really deliberately about how we can ensure that when we are creating alternatives to healthcare systems, that we are making them as equal as possible and as accessible as possible. So that's understanding some of the restrictions that people might have. Some of that is to do with access to data. There's been some really interesting reports by Nesta, and they are looking into how much data poverty there is. So they've termed the phrase, or they've got this from some people in Wales, in fact, about data or dinner, where people are having to make decisions about whether they're spending money on access to digital or if they are going to spend money on food. So we have to recognize that there are some restrictions. But on the other hand, if you allow people access, if they're quite remote from where their healthcare is normally positioned, then it's fantastic that they don't have to travel all those distances and wait all that time. I personally also think that there's a real opportunity for health to partner with the voluntary sector in places where people are really keen to get people more digitally accessible. I don't think that's a term, but people
just now.
But enabling people to have access to digital things, because let's face it, there's so much in the world that people are being disadvantaged from if they aren't able to access things. But I think that because healthcare can be that moment where people suddenly really need to access digital systems. But I think we have a responsibility then to both be influencing people's access to digital technology and data, and also to be partnering with those people who are passionate about people who otherwise would struggle to get that, to help enable that in our local communities.
Oh, it breaks my heart when you talk about, people making that choice between accessing the data or food. That's just not a position we can be in. And I know, Lisa, that you've got thoughts on, remote care and the impact on health inequalities. Do you want to carry on from what Catherine was saying there?
Yeah, completely. And I think the main principle is that it always needs to be a choice. It always needs to be a choice whether patients want to or prefer to or need to come in to see their clinicians for all sorts of reasons. Some are related to the clinical risk. Some are related to the fact that digital technology doesn't work for them in all sorts of different ways, and some are exactly the issues that Catherine's described around access to data. So we always need to make sure that patients can come into hospital. So when I was running a number of hospitals in my career, and I know that probably about 50 to 75% of patients probably would prefer not to be in hospital, and yet we have very busy outpatient clinics and waiting rooms, before the pandemic, to the extent that people couldn't find a seat to sit down in the outpatient areas, and we're waiting quite a long time. So we need to make sure there is a choice for patients, and this is about broadening access, making sure that if people just want to ask a question by email or by text, they can do that. And if people need to come in to see the clinical team, they're able to do that as well. And I think previously we've been funneling everybody through the route of you have to come in to see people at the hospital rather than giving the flexibility. And of course, the key thing about that is supporting our clinical teams by making sure that the systems and structures are there to support them, that they feel safe, that they won't lose patients in a some kind of tech waiting space. So those building those systems that are reliable has been one of the key things that we've been trying to do over the last 2 to 3 years to make sure everybody feels comfortable in using them. They're easy for patients and easy for clinicians as well. And I think it's probably important to note just the breadth of services that we're looking at. And Alexia gave a fantastic example of blood pressure monitoring. We all know it's one of the key indicators of heart attacks and strokes. So really crucial. We have a similar scheme in the UK. I do think Scotland is ahead of us. So just to give a call out for the fantastic work that's been done in Scotland. We've also created remote care on, I think I mentioned gastroenterology, cardiovascular and respiratory care, but lots of programs now emerging on rheumatology, MSK, ophthalmology, dermatology. The rise of teledermatology has been phenomenal across the country, and this has all been prefaced on getting people access to their diagnosis and advice and guidance sooner. So I think we're going to see a rise in all of that, but also, as Alexia said, the just better advice and guidance that is now being curated so beautifully by clinical teams and being put on lots of health system websites, better videos, better self-help. All of the quality of all of that information, usually in collaboration with charities, is rising substantially.
I think two quick questions. Just sticking with you for this one, Lisa, because we've addressed most of this, I think. But Shoshana says, how does the panel feel we need to consider and address the needs of vulnerable patient populations so that no one gets left behind through the scale and pace of digital transformations? Actually, I think we have already probably answered that fairly fully. But also Mike says, talking of blood pressure, I'm monitoring mine at home at the minute, which is it's fantastic because I get white coat syndrome if anybody like Alexia takes my blood pressure. But Mike says, are you concerned about the calibration of, for example, home blood pressure monitors and INR machines versus clinical machines?
Sure. Yes, and this is something we've been considering. Certainly, we know across England there's around 3 million blood pressure monitors that people have at home. We purchased another 200,000 at the start of the calendar year just to make sure that everybody had access to them, that needed them, and we were particularly focused on parts of the population that needed greater access. So we do follow some advice and guidance, and there's some nationally prescribed tools. So certainly, if you've bought your blood pressure monitor in the last 5 years, it's likely to be well calibrated. And one of the most important things is that people take their blood pressure monitor, take a trend. This Alexia will know more about this than I do, but there's some really good, excellent tools out there. This is not new technologies; it's technologies that has been out for a while and has been able to be well calibrated. But the breadth of information in terms of taking a trend and taking information over time is important. And then I think some of the areas around vulnerable people within the population, we're doing further work at the moment on people who have a whole range of different long-term conditions who are quite fragile, and I think we're kind of in the testing phase at the moment, but what we're trying to avoid is that kind of bouncing around the healthcare system that we've seen when people do have a whole range of different conditions that they need to be treated, and just to see how we can coordinate that with one digital platform, and only bringing patients into hospital when it's absolutely required. So I think we're going to hopefully see some better coordination, but I think we're at the start of dealing with some of the really complex patients at home.
I think, Alexia, we were talking in our first panel a little bit with the breast cancer expert, a little bit about breast cancer patients and how, whether for people with long-term conditions, it's quite nice in a way, not always having to come into the surgery, always have to go into hospital for some of the things that can be done at home, because perhaps it's a welcome break from realizing just how sick you are. I have a friend suffering with breast cancer at the minute and going in for her chemotherapy. She's at the beginning of her journey, and it always does a lot to her, looking at other people who are much further down the road and who look very poorly. Have you seen that with some of your patients, that some of them welcome to be able to sort of do their things in the home without always having to be constantly reminded? I'm thinking of the long-term sick now.
Absolutely. I think the story you tell there as well of your friend who is recognizing that there can be negatives attached to going into hospital, going into that big shiny building, the scariness that can be behind that is definitely a story that I've heard from other people as well. And it's that, but also in the area that I work in, we're a semi-rural area, and the rurality and the rural deprivation that exists is a story that I hear louder than the one that you mentioned. So we found that, and we did some research into it. So in one area of Ayrshire, 19% of people are without connectivity. So we didn't want them to be excluded, but also on top of that, for their weekly unemployed income, for them to travel into hospital was taking up a fifth to a seventh of that amount of money, which is huge. So I think there's that as well about why people prefer to have local services, or to be able to not even need to leave the home to be able to do that. And the issue though about connectivity versus economic deprivation, when we're thinking about tech and using it in healthcare, is we're really fortunate that locally we've got Connecting Scotland, and we've also got community connectors who are the community link workers. So we know that we can avoid exclusion there and get some support and get some devices there from the third sector to be able to help them and to save that is a vast amount of money, isn't it?
Absolutely. I think what's coming loud and clear, Catherine, in all of these debates really, and debates that we've had at this event on other occasions, is that it really isn't a one size fits all. And we've got to make sure that as we embrace technology, which, with my family, we've found some of the digital solutions have been absolutely brilliant for us, but we've got to make sure that there's a whole mixture of options and we embrace technology in the right way, haven't we?
Absolutely. I think another thing to consider within this is around trust, and how people are sort of presented with technology, how it's introduced to them, how it feels trustworthy and safe. So there's the sort of safety around the clinical reliability and ensuring that things happen appropriately according to people's condition. There's also safety around a person's own situation. So one of the things that we sort of take for granted about face-to-face interactions is that they're going to take place in a space. We've talked about the issues of people getting to that space. We haven't really I haven't thought so much until now about how some people just find the interaction with any healthcare professional quite an intimidating and an off-putting type activity. There isn't necessarily the automatic trust there that perhaps I have, because I've got real confidence in the healthcare system. But we know from highlighted by the vaccine hesitancy that there's all sorts of issues that people have. So when we are developing remote health solutions, we need to think about how are people encouraged to trust this as a system? How are they being reassured? Even those people who aren't perhaps reassured by the conventional ways in which we approach healthcare. And I think that's a whole fascinating other area for us to explore. And we need to do more kind of in-depth knowledge of what people's experience of the kind of user design of how we're developing services is really, really key if we are going to make equitable services and for a range of different people and have those different options.
You're right. I mean, trust is key, as is safety. Lisa, what are your thoughts on how we can build that trust and make people feel more confident?
Sure. Yeah, we've done some initial evaluations of the early remote care work through the pandemic and post-pandemic on a range of conditions, and there are some really important themes. The first one is around a really good induction into remote care and the systems. People do trust their clinical teams and their own doctors, and that's really important that the introduction is from that initial clinical team, that people are very comfortable with different types of care that they're receiving, and that's been a real driver in people being happy and to be using different digital platforms. So that's been really important. When that has happened, and it's in majority of cases, we're getting feedback that it's between 90 and 95% of people are delighted with the service. So that is that is really good. And I think what Catherine and Alexia have said, that this absolutely isn't a one size fits all. So we know that that people will become increasingly confident as these tools are rolled out across the country for a whole range of different services. Their attitudes will change, and interestingly, I think there is concern quite rightly about leaving people behind, but the most recent kind of public panel that I was on, people were saying, hang on a minute, you're just not going fast enough, because I want to be able to manage my own condition. I can if I'm in the US. In the UK, you just don't have access to those types of technologies and apps. So I think we've got to make sure we work hard to include everybody, but also to make sure we don't slow things down so much that a whole range of patients opt out because it's not fast enough, or it's not linked in with the quality and sophistication of technology that you're used to dealing with, and where we can put patients at the centre and make sure that they can have all the tools to manage their condition. That's absolutely what we should be doing. So I think getting it right in terms of that range will be a key to making sure people feel comfortable.
I think you're right, because it can actually feel quite empowering managing your own condition, I think, and that's only likely to increase. I mean, Alexia, it sounds like you've done a lot of work on trust, and you've had you said at the beginning, you've had very positive feedback from your patients. All of these pathways sound great, but are they going to be backed up with evidence of their success and then continued as we come out properly of our pandemic situation that we sort of kind of still find ourselves in?
Yeah, so definitely they are, both the national and the local pathways have got patient evaluations as outcomes embedded within the pathways themselves, which gives patients opportunity to feedback. And although we have been in part using the Scottish approach to service design, which is a double diamonding, including patients along that journey, that has, I think, as Lisa said, that has an issue with the time that it takes to do. So it's probably been a very concise version. And instead, what we're doing is using more of an iterative approach and having this free text option for patients to be able to give their feedback to how they found using each of the pathways. And we're really actually using that to be able to then hone and tweak and take this really from it's an electric scooter into this is a Harley Davidson of tech healthcare, which is suiting patients as well. Because the main priority, in all honesty, when this was being pushed throughout the pandemic, was to be able to support the NHS and support these systems that need to happen to keep patients safe, support that there when the workforce really wasn't there and the pandemic was overwhelming. So the evaluations are definitely happening, and those results are going to iteratively come through. We're not just going to have one point of assessing and redesigning. This is going to be quite an innovative and fluid catch of all of the feedback and making sure that it is people-centered, not just a healthcare system.
And Alexia, where else in that healthcare do you think there's potential for using technology-enabled care to support the NHS more widely?
So I, again, can see the future. And although this is important right now, I think there's a real possibility and potential to use tech for preventative healthcare. So the idea of creating screening programs that use tech efficiently to make that service more cost effective, but be able to make it more accessible to patients as well. We've actually locally tested an AF screening program because we know atrial fibrillation, AF, can lead to stroke, and the stroke burden costs to NHS Scotland are about 5% of the total. So that is a huge amount and a huge cost burden that's there. And the pilot itself in prevention that we've been running alongside these sorts of reactive pathways for the pandemic, those proactive pilots we've been running have put that screening program within community pharmacies. So it's somewhere that the patients have been accessing to collect their scripts anyway. They're able to get that screening process done. And we've had a numbers needed to treat of being 27 for the over 65s, which is great. Just 27 people being screened for 30 seconds. We're detecting one case of atrial fibrillation. So I think preventative methods, that's where we should be going anyway, shouldn't it, to reduce the long-term conditions and reduce that health burden would be great. And I think also looking at practical things, like I said about blood pressure monitor devices, it's difficult to keep up with the supply of those, and there's a cost associated with it. But you have to think, for patients with asthma, they'll be given a peak flow meter on a prescription, and prescriptions in Scotland are free. And it's things like, could we actually put blood pressure monitors onto prescriptions to make those more accessible and take away those inequalities again about those devices shouldn't just be for people that can afford them, they should be there for everybody to be able to access.
That's a nice sort of way to end, Catherine and Lisa. I'll get your sort of final word, just both of you briefly, on the future of remote care and whether you feel like, Alexia, that there's a big piece to be done in terms of prevention of illness. Catherine, do you want to start us off, and then Lisa, final word?
Thank you.
We have to keep it brief because we have a film coming up.
Okay, no problem. Yeah, I think there's also opportunity for keeping people informed about what's going on in their healthcare journey or experience. I think we still aren't that brilliant in the health system of helping people know what appointments are coming up, what's the next test. Some of that, there's a real opportunity for digital technology to help there. And I totally agree with the prevention opportunities as well.
Lisa, no pressure. Final thought.
Yeah, no, great examples that people that Catherine and Alexia have given already. I think we hopefully will see over the next 5 years that long-term conditions are care is transformed phenomenally. I know patients that I've spoken to have said they're not looking forward to getting older and having 2 or 3 visits to hospital every week. They want to live their lives, not be constantly organising their lives around visits. So I think there's phenomenal things that we can do for patients, but also the virtual wards that we've seen being adopted around the country, where patients are admitted less frequently, managed safely at home, and the impact that has on their lives, I think, is not to be underestimated.
I think you're right. Thank you very much, ladies. It was fascinating talking to all of you. Thanks to everybody who took part in this panel. Now, whilst the pandemic was a challenging time, of course, for so many people in so many different ways, it's positive to see what lessons and improvements we've managed to take from the experience. So to continue sharing knowledge and insights this morning, James Balmain, Chief Executive Officer from Induction Healthcare, is our guest on the virtual stage with this pre-recorded film.
Hello everybody, I'm James and I work for a company called Induction Healthcare. It's really great to be with you all today, and I hope that my talk piques your interest enough to learn a little bit more about Induction, our products, and how we're supporting the NHS. We're really focused, I suspect, like a lot of other people, on recovering elective capacity. And for a healthcare IT company like Induction, that translates to reducing waiting lists. So we're working with a significant number of providers now to deploy our technology to enhance the care pathways, make them more efficient, remove unnecessary appointments, and give care teams the flexibility to run consultations with patients, wherever they are. Now, this concept of flexible care and our mission as a company to build an end-to-end flexible care platform is important, because when we think about flexibility, we think about absolutely supporting face-to-face consultations alongside more remote mediums. So when we think about providing tools that enable care teams and patients to communicate, we think about face-to-face, we think about video, we think about telephone, which is widely used, and we think about asynchronous messaging. Another key part of our ethos as a company is our relentless focus on making our products simple to use. Now, making something simple is actually quite hard, but this idea that our products are those that clinical teams and patients choose to use is really, really important to us. And then finally, last point to land on this slide is around scale. You know, many of our products are used regionally, some of our products are used nationally, and we're really, really focused on providing that regional capability so the patient logs in once, regardless of the care provider, the care setting that they're being treated through. So I want to spend some time today talking about 3 of our products and how they're helping reduce waiting lists. The first is Attend Anywhere, a company we acquired earlier on this year. Many of you, I'm sure, will be familiar with the platform. It's a video consultation platform built from the ground up to support healthcare. It's operating at significant scale in secondary care and increasingly adding a lot of value in community care as well. Secondly, I want to talk about our patient portal product, Zesty, and in particular, its appointment management capability that's allowing patients to book their own follow-up appointments, patient-led booking. And then finally, a new product we launched a couple of months ago called Form Builder. We've been building this for the last 18 months in partnership with a few of our key customers. And it allows care teams to design and deploy digital forms for patients, enabling that remote data capture. Now, each of these products is exciting and is adding value in its own right. But what really gets us out of bed in the morning is the idea of combining all 3 of them across the same care pathway. Now, we believe when that happens, the results are going to be really compelling. So I want to talk about Attend Anywhere first. NHS England commissioned a company called Edge Health to produce a report. It's well worth a read. There's some really great data in the report around the rise of the Attend Anywhere platform and some key metrics around how video consultation scaled under huge pressure as a result of COVID in secondary care. In the last year, the Attend Anywhere platform was used to conduct over 3 million consultations, which is naturally 3 million in-person visits that didn't happen. But on top of that, they estimate, NHS England, that 35,000 ED visits were also avoided, delivering significant benefits and cost savings to the system. And when we think about cost savings, the one to point out as a measurable saving is the value of around 6 million that was saved through a reduction in did not attends. And what they found when they did the study was there's about a 4% differential between a video consultation and a face-to-face consultation. Now, at Induction, we believe we can enhance that differential further by streamlining the patient onboarding process. And then finally, NHS England estimated over 1,700 non-COVID infections were avoided, again, delivering further benefits to the system and cost savings. So the big message I want to land on Attend Anywhere, which I think is quite obvious, is this is the platform, particularly in secondary care and increasingly in community care, that is being used at scale across the NHS. Attend Anywhere and increasingly Induction are making really significant investments in infrastructure and product enhancements as we move forwards. One thing that we do have a few conversations on is what's the difference between a platform like Attend Anywhere that's specific to healthcare and the business conferencing tools like Zoom or Teams. And so we've done this slide to try and illustrate one of the biggest differences between the consulting model and the conferencing model. So on the left-hand side, you've got the Attend Anywhere model where there is a virtual waiting area. So that virtual waiting area is designed to mirror the physical waiting area you might have within the provider care setting. patients are given a link to join that waiting area, not to join an actual consultation. They wait in that waiting area until they are called into a secure consultation with their clinician. And the clinician has complete control over which patient to put in when, making that clinician-patient consultation very secure. On the right-hand side, we've got the conferencing model, where every consultation between a patient and a clinician has its own individual link. Now that works at small scale, where you might be wanting to do ad hoc consultations with patients on a pathway, but it becomes really unwieldy when you try and use it at scale, because every patient needs their own unique link. And it also presents, what we think is quite a significant security risk, because another patient can join a consultation that's not meant for them if they're given the link. So on the left-hand side, on the consulting model, it's one link for the whole pathway where many patients can join the same virtual waiting area. On the right-hand side, thinking about the conferencing model, every patient needs their own link, which makes it really, really challenging to manage at scale. And the final point I'd make on the difference is one of just straight up security. Platforms like Attend Anywhere are designed to leave absolutely no digital footprint, whereas other platforms, global business conferencing platforms like Teams and Zoom actually do leave quite a significant digital footprint, unless the patient knows where to go to delete things and clear things up. What are we doing with Attend Anywhere moving forward? Well, the big one for us is to leverage our capability in EPR integration. And we've got 3 key deployments we're going to be doing in the coming weeks. The first is workflow integration. So if a provider is running a capable EPR, they'll be able to launch Attend Anywhere directly from within EPR, rather than running dual screens. The second is check-in to PAS. So when the patient lands in the waiting area and they enter their demographics, instead of just registering within the Attend Anywhere platform, we'll send a message into PAS and check them into PAS, preserving all of those downstream workflow events that you would see from a physical check-in kiosk in clinic inside the provider's premises. And finally, I want to talk about patient onboarding. I talked earlier on about this 4% difference in DNA rates, where patients are 4% less likely to DNA if they're using Attend Anywhere. We think we can really grow that number by providing a digital message to patients, as opposed to the URL for the waiting area either being published on the Trust website or going out to the patient in a letter. And then finally, we've been working all year on a really capable group consultation platform, and we're really excited to say that's going to be live and in the wild in the next few weeks. There's a number of, we've run a few user groups with our customers. You may have been on one where we've run it on AA groups. It's a fantastic achievement, and it's working really, really well at scale. Next, I want to talk about our patient portal platform, Zesty. Now, Zesty has 2 key capabilities. The first is it gives patients access to digital copies of their correspondence. And by correspondence, I mean their appointment letter, their clinic letter, and even their discharge summary. Anything that's designed on paper to be posted to a patient can be published on the portal digitally. Now, we capture the patient's preference to go paper-free. And if they say, yes, I don't want paper copies, then we work with the trust in question to stop that paper going out, generating quite a significant cost saving at scale. But more importantly, when thinking about elective recovery and reducing waiting lists, is our appointment management capability. Now, in the vast majority of sites where Zesty is currently deployed, that's based on a bi-directional integration with the underlying electronic patient record and PAS platform. And we have some really strong partnerships, particularly with companies like Cerner and System C, where they're supporting us in that interfacing, and we are going to market alongside those 2 companies. Now, that appointment management capability is important to enable patient-led booking. So one of the big drives that we're working on with a number of our customers now is to empower patients to book their own follow-up appointments, as opposed to being given one as routine. And it's widely understood that if we can get that technology working at scale, we'll significantly reduce the number of follow-up appointments that are actually required in a given care pathway. Now, there's 2 more points to make, I think, on Zesty. Firstly, we began life with that product as a patient portal for hospitals, but increasingly we're now looking at regional deployments. Now, we won the contract with South West London alongside our friends at Cerner earlier on this year, and we will be going live in the coming months with them in South West London for a regional portal where, regardless of care setting, the patient can sign into the South West London portal, and they only need to sign in once, and they'll have access to appointments and documents across community, primary and secondary care settings. So we're really excited about that, and we think that's absolutely the future direction of travel, where care is going to go regional and be supported at an ICS level for platforms like Zesty. Then finally, if you want to learn more, you can go and have a look at the NHSX digital playbook. There is one for Zesty and worth a read. Thinking about how far we've come now, we have about over 360,000 patients registered on the platform now, and it's growing at around just under 30,000 new registrations a month. We think we're on target in the next 12 months to break that 1 million patient barrier, which is a huge milestone for us as a company. I also want to talk about registration rates. So if you take an average of registration rate across all of our deployed customers, you get the number of 68%. And to be clear what that means, for every 100 patients that are invited, 68 successfully register and transact on the platform. So registration rate is something I'd really encourage you to think about, because you can have the best portal in the world, but if nobody can get on and use it, it's not going to deliver value. We've delivered over 1.5 million digital letters now, and we're seeing very roughly, as an average across all of our customers, just over a 70% opt-in rate to paper-free, delivering that cash saving. And then finally, we see across the board as an average a reduction in overall DNA rate of over 30%. In fact, we have some customers where DNAs are reduced by more than 50%. That's a really, really meaningful number. And again, we think one of a number of things that are key to deliver elective recovery at scale. Finally, I want to talk about our form builder product that I alluded to at the beginning of the talk. This is a platform that allows care teams to design and deploy digital forms for patients. We built it in partnership with some of our key customers, so we've really got under the skin of how that process should work in a secondary care setting particularly, and we're excited about the capability this will have when we start to roll it out at scale. We did a piece of work at Guy's and St Thomas, particularly looking at that completion rate. So if we send a form to a patient, how likely are they to send it back completed? When we began in the first week of our trial, we were seeing around 30% completion rates. We did a lot of work on the content and messaging, the number of invitations to send, reminders, usability, and we moved that 30% to over 80% in a 12-week period. And we supported over 2,500 patients. And the final thing I'd say about Form Builder is we've designed it with both conditional logic and scoring out of the box. So we think it's a really powerful tool that can be used for a whole load of different things, from risk assessment to risk stratification, to surgical pre-assessment, and even things like friends and family have already been really successfully run on Form Builder. Oh. So to wrap up, our vision of that integrated flexible care platform in our heads runs across 4 key pillars. The ability for patients to manage appointments in a seamless way, including that really important patient-led booking. The ability for patients to get digital copies of their correspondence. That virtual consultation mechanism, which absolutely will support telephone in the new year on the Attend Anywhere platform, and group consultations. We're not ignoring telephone. We know that telephone will be around for quite some time, if not forever. And then finally, using our Form Builder product to design and deploy forms for patients. Now, one of the other things that we're working on, not directly in our own platform, but in partnership, is also giving patients access to copies of their clinical records. We launched, for example, health records on iPhone with Apple and Cerner at Milton Keynes last year. And we're working with other providers like System C and a whole host of other personal health record providers to enable single sign-on links from our platform into those PHR platforms that might be deployed either at an individual provider or as part of a local shared care record initiative. So hopefully that's been helpful in terms of letting you know who we are, what we're doing, and what our vision is for flexible care. Thank you for taking the time to listen to me. And I hope you'll have a look at our virtual stand and get in touch and learn a bit more about what we're doing and how we might be able to help you.
Well, thank you, James, from Induction Healthcare, for sharing that talk with us. We're going to take a really brief break, a quick opportunity to network with other delegates and to recharge and process all the knowledge that's been shared already. So enjoy. Our next session starts at 11:35, which isn't long. I'll see you then.